Okay. So while some of this information sometimes may be useful, or much of it is incomplete, misleading, and not supported by scientific evidence. Because when you are going to a doctor, all are trained. Basically, they are completed an MBBS and diploma in ortho or a MS ortho. So they are completed and they know the science behind that. They know the complete pathology. Okay. And unfortunately, this often leaves people confused because of so much of information flooded in the social media. So most of them, they are not unable to take some decision. Sometimes they are very confused actually. What happened this scenario, sometimes it can lead delay proper treatment option, or even sometimes it lead to serious complications when it comes to the long term damage. So people sometimes, most of the time, people are coming to the doctor at the last stage of the arthritis, for example, and they are looking for some quick fixes immediately. But if you are treated the disease in the initial stage, just think it. That's why this webinar. So the idea behind this, we are going to give some knowledge. The doctor is having a good exposure. He is going to give some knowledge about the basic of knee pain and why knee arthritis is happening. So that is why this webinar today. With that, I am going to introduce on behalf of everyone, I am going to welcome Dr. Joel Prasad sir. On behalf of Avana Surgical, as well as on behalf of everyone, I welcome Dr. Joel Prasad. First of all, thank you very much, Doctor, for accepting to host this webinar. Uh, in your busy schedule, you are accepted to host this webinar. Thank you very much for that once again. And I would like to add some few words about the doctor, and then I'm going to leave the session to him, actually. Dr. Joel, sir, has completed his MBBS from the esteemed Government Medical College as an Institute of Medical Science. And he then pursued his post-graduation in orthopedics, and he got a diploma in ortho from Father Muller Medical College, Mangalore. He completed a DNB in orthopedics and traumatology from Niyat Hospital, Chennai. And he's having a very good exposure in all the segments of sports medicine and general treatments, everything he used to do that. His dedication to enhancing his clinical expertise lead him to a postdoctoral fellowship in shoulder and upper limb surgery under the guidance of the Shoulder Elbow Society in India. Okay. So additionally, he completed fellowships in arthroscopy and sports medicine, and he is an expert in computer navigation arthroplasty, which is very advanced. Now you know that most of the all the hospitals, they are focusing on the robotic knee replacement surgery. Okay, in that he is an expert in that. So with that, I'm going to stop, and thanks to everyone for joining this wonderful webinar. And again, I'm thanks to Dr. Joel sir. With that, I'm going to leave the session to Dr. Joel. And I have one small request. In between, don't ask any question. Once the doctor completed the presentation, if, if you have, I have already collected some few questions from all of you. So that will be addressed by the doctor. After that, if you have any other question apart from that, the doctor is going to discuss directly with you. Thank you very much, doctor. Thank you. Now you can. Okay, sir.
Yes, thank you, Mr. Ramesh. Thank you for the brief introduction which you have given. I would like to thank all the participants who has really taken their time off in this evening schedule in order to join this webinar. I hope I'll not be wasting your time. I'm going to be very brief. I'll be very quick. I will not be divulging much into the theory, but I would like to deal with the practical aspects of this knee pain. Many patients come to us with knee pain. Some would have been recommended surgery. Some don't want to get surgery done. Some is not fit for surgery. Some patients, though they don't need a surgery, they have got the surgery done. So we will try to differentiate each one. And also say, my goal with this seminar is how to identify arthritis early, and knee replacement is not the final treatment for arthritis. We do have a number of treatment options before. So I would like, all those who have joined to be well versed with all the treatment options, and then accordingly take a call. So at the end of this webinar, so every participant here should be able to understand at what stage of arthritis they're in, what are all the treatment options they're having, what are the treatment options which are not available for them, do they really need a surgery, or can we manage them conservatively? So I'll be extremely brief. I will give you more time to ask questions so that all your practical difficulties and your doubts as well, may be taken care of. So very briefly, I'll explain. So what is this arthritis? So arthritis means that there is degeneration in the knee joint, typically because of the wear and tear. So invariably, what happens is the articular cartilage. So articular cartilage is the lining layer inside the bone. So we have the thigh bone and we have the leg bone. So this articular cartilage lines the border of this bone so that they will glide easily, and then they will glide without any friction. So in arthritis, what happens is the articular cartilage will get eroded. Now there are two types of arthritis which everybody should know. One is called a primary arthritis, and other is secondary arthritis. So what does primary arthritis mean? So primary arthritis means that there is no cause. It is basically a age-related arthritis, age-related degeneration which happens without any cause, without any injury. And what is secondary osteoarthritis? So secondary arthritis means that there is arthritis because of a reason. So it can either be because of an injury, because of an infection, because of an old fracture, because of rheumatoid arthritis, because of some kind of an inflammatory cause. So there is some cause preceding the onset of arthritis. This we should always differentiate. Anytime you have a knee pain, so in case you had an injury before, you had some kind of issue in the knee, and now the knee pain has increased, it means you have a secondary osteoarthritis. If you're completely fine, absolutely no injuries, no infection, no swelling, and all of a sudden, if your knee has started to hurt, if your knee has started to swell, that means that you're having primary arthritis. Now, we are having different grades. So we have, it's called as a KL grading system. So we have grade 1, grade 2, grade 3, and grade 4. In grade 1, patients will be normal. So probably all of our x-rays, if we get it done today, all the youngsters probably will be having grade 1 arthritis, wherein we will not have any features of arthritis. So in grade 2, what happens is there will be very small lipping of the bone with very doubtful reduction in the joint space. So usually when we see the joint space on the outer side and the inner side has to be same. So in grade 2, on the inner side, some amount of reduction will be there. So what happens in grade 3? So in grade 3, the patients will start becoming symptomatic. So when they're sitting on the floor, when they're trying to get up from a seated posture, when they're using stairs, when they're walking briskly, slowly, still at the end of the activity, they come to us with pain, they come to us with swelling, and they'll come to us with some kind of a stiffness in the knee as well. So most of the patients who come to hospitals to seek help will be in this grade 3 stage. And in grade 4, when we see the joint space will be completely obliterated, there'll be bone on bone erosion, and there'll be cyst formation, and there'll be a lot of lipping. So in grade 4, we have very less treatment options. In grade 3, we have a lot of treatment options. In grade 2, again, we can completely avoid the progression to grade 3 and to grade 4. Now, what are the common symptoms? When patients come to us with arthritis, the most common symptom is pain. But what what is the character of pain? So we see that the pain is usually gradual in onset. There is no sudden sharp onset in pain. The pain will always be slow, and then it slowly proceeds over a lot of weeks and months before it becomes severe. And also, this pain will be worsening with activity, especially with prolonged activity. Like in case you're standing for long duration, you're walking for long duration, you're bending and doing some kind of a work for long duration. In case you're sitting cross-legged for long duration, all these activities will start leading to pain, and it will worsen the pain. Sometimes repeated climbing upstairs, downstairs, repeated bending forwards can lead to pain. And sometimes, even if you don't do anything, suppose you're just sitting idle on a chair, you're sitting for half an hour to 45 minutes, and suddenly when you get up, you might have that sudden catch. Okay, and even that will also lead to pain. But this pain will always become better with rest. So some amount of rest you give, the pain will subside. But again, the moment you start walking or doing some kind of activity, the pain will definitely increase. And sometimes with icing, some medications, or the pain will definitely subside. In addition to pain, other the most common symptoms they come to us is also swelling of the knee, sometimes stiffness of the knee. Sometimes the patients will even come to us with a sense of locking. Now, they'll not be able to straighten or bend the knee. It will be really difficult for them to move after that. And sometimes their walking capacity also will start reducing. Now, we have got a lot of risk factors for this osteoarthritis. Some are modifiable, some are non-modifiable. Now, what are all the non-modifiable risk factors? Like suppose in case you're aged over 50 years, that is something you cannot reverse. You cannot reverse your age, And usually we have seen females being involved more than the males. So these are all the non-modifiable risk factors. Sometimes genetic factors, wherein either your ancestors, your parents, they might be having arthritis. So there is a genetic predisposition as well. Now, these are all the non-modifiable risk factors. Now, what are the modifiable risk factors? Modifiable risk factors are the ones which we can modify so that we will not get arthritis in the future, such as excessive weight. So, if your BMI is more than 23 to 25, so slowly, what happens is the amount of stress on your knee will increase significantly. And so this is something which you can modify by reduction in weight. You can modify this risk factor. Injuries can be modifiable. You'll have to be a little careful. The high impact physical activities like sporting, jumping, running, all these activities you'll have to train well and also reduce the impact. As well as habitual sitting on the floor, kneeling, squatting, sitting cross-legged, all this if we can reduce a little, the onset of arthritis as well as the progression can be avoided a little. Now I will go straight away to the treatment options. So we are having a lot of non-surgical treatment options as well as the surgical treatment options. Now, uh, most of the patients subset who come to us will be able to get relieved of their knee pain by the non-surgical treatment options. So not every patient needs a surgery, and any patient who comes, it is not fair to advise a knee replacement directly because we have to exhaust all these options. So we have patient education, we have your lifestyle modification, we have to do some kind of a physical therapy, that is a physiotherapy. Weight loss will help. Some amount of knee bracing will be required. Medications, again, we're having different classes of medicines which will help with the arthritis. We have a specific group of medicines called the glucosamine and chondroitin sulfate. So what these medicines do is they try to restore the cartilage. So they help with the joint lubrication. Now, in addition to these tablets, we are having some kind of special injections as well, which we inject directly into the knee, though their mode of action and their outcome will be different. So, corticosteroid injection. So, we give a locally acting steroid into the knee. It will reduce the inflammation, can reduce the swelling, and can reduce the pain as well. And we have a special injection called as hyaluronic acid, which again we inject directly into the knee. This is more like a visco supplement. So, it's basically a gel-based injection because most of the patients with arthritis, when they come to us, most of the liquid inside the knee would have got absorbed. There will hardly be any liquid, because of which there is bone to bone contact, and which can lead to progression in the arthritis. So injections like this hyaluronic acid, once we inject into the knee, will give immense relief. So there will be immediate relief in pain. Their range of movement improves, their activity and their life will also improve significantly. Now, I will briefly tell you, what kind of activity modification the patient should do on a regular basis. So one is cardio and then doing aerobic modifications. So most of the patients, elderly patients, we know that they don't do anything other than probably walk. So they go for a recreational walk in the mornings and evenings. So there is no other activity they do. Working out in the gym, very small subset of patients do that. So one activity modification which they can do is that instead of stressing the knee, they can start switching to much more joint friendly exercises, such as instead of brisk walking, instead of running, instead of walking for long duration, they can start swimming. Because what swimming does, it reduces the load on the knee joint, because the water itself will start supporting some amount of weight. Then instead of walking, again you can use stationary cycles, recommend bicycles, because this will start building strength without loading the knee joint. And even an elliptical trainer as well. Even so, what this does is it helps in the restoration of the knee strength. Your quadriceps will get strengthened, your hamstring will get strengthened, your calf muscles will get strengthened, as well as these are important for your cardiovascular health as well. And very important lifestyle modification for every patient who has got knee pain is they have to avoid squats. Most of the patients will not be doing that because they'll be having the commode in their house. So squatting will be minimal, but sometimes sitting on the floor, sitting cross-legged, doing all these lunges, all this also has to be avoided. We advise the patients preferably to sit on a chair by not bending the knee beyond 90 degrees. So 90 degrees should be the limit so that the amount of stress on the knee will not be more. Now, which are all the other adjustments can be done? We can do daily, physical environment changes as well, such as avoiding the low chairs. Instead of sitting on a very low sofa or a chair, use something firm and use something higher so that your knee will not be under tremendous pressure, whenever you're getting up or even when you're trying to sit down. And also avoid repetitive kneeling, because the more you kneel, so kneeling requires requires a lot of effort. When getting up from kneeling posture also needs a lot of effort. So there are a lot of muscular forces which are acting on the knee, so which can in fact progress the arthritis. And also using structural leverage, like trying to push heavy doors, we using the shoulder or hip rather than the knee. And also lift with the larger muscles. Use your hip muscles, your calf muscles, more than using your knee muscles. Now, other strategies where you can avoid the progression of the arthritis is like, try to take frequent breaks. Like, you can fractionate your walking. So instead of walking continuously for half an hour, 45 minutes, you can split that. 10 minutes each time, 3 to 4 times per day you can walk. And also you should keep introducing rest intervals as well. And also slow down. There is no harm in slowing down. Okay, the more you pace, the more your breaks, the more you're fast, the damage will also be faster. So slow down on your walking, and so that the joint reaction forces will be less. And also lower external weights, as in, prioritize much higher repetitions with lighter resistance over heavy lifting. All this will be much more beneficial for your knee health. Now, coming to the physical therapy, there are a lot of exercises, but all these exercises mainly take care by strengthening the quadriceps muscle. It will strengthen the hamstrings and calf, so that the muscles will start absorbing some amount of stress, instead of the bone taking all the stress, instead of the joint being loaded so much. What happens is, with all these exercises like the knee flexion, hamstring stretches, leg flexes, these are all very simple exercises. You don't need a trainer, you don't need a physiotherapist. All these exercises can be done on your own at your house. You do it 2 to 3 times per day. The muscle quality improves, the muscle strength improves, and so in that way you'll be saving your joint as well. Now, what is the importance of weight loss in the knee osteoarthritis? So we can see. So the way weight loss affects is, for each 1 kg reduction in weight, the stress on the knee reduces by close to 4 to 6 kgs. So it's directly proportional. So indirectly, when you see, so in case you gain 1 kg of weight, so the stress on the knee will be almost 5 to 6 kgs. So in case you have gained 10 kgs weight, so that's almost 40 to 60 kgs of weight, which is a tremendous amount of pressure on the knee. So what happens is, because of this axial loading, so this gap, what should be there, the gap will start reducing. So as the gap reduces, the bone-to-bone contact will start happening, and that is when erosion, friction, arthritis, loss of cartilage, all these things will happen. So weight loss is extremely important. So sometimes patients might ask, some patients, because of the pain, they cannot do exercise. So when that's happening, you can always shift to something like swimming, low impact activities, reducing your threshold, trying to manage your diet. So all this will definitely help you. So reduction in weight is extremely important for every patient, irrespective of the grade. Sometimes patient having this grade 1 or grade 2 arthritis who are overweight will quickly proceed to grade 3 and grade 4. So in case a patient is overweight in grade 2, he loses weight, there's a very high chance grade 2 can become grade 1. So that's the importance. So, and then the other thing, the other conservative management option is bracing. So bracing, so if you go to any of the orthopedic doctor, they recommend some kind of a braces. Some will recommend braces like this, which are just like knee sleeves. Some will give you a hinged brace, and some will leave this offloading braces. But I would want everybody to know when we use each one. So the neoprene knee sleeves can be used for early arthritis. So grade 1, grade 2, and very early grade 3, we can use this, because this gives good amount of compression. So as it gives compression, the swelling reduces, some kind of a support to the knee joint will be there, the pain also will reduce. And since the support will be there, the patient will be able to walk better. Now, coming to this hinged knee braces. So hinged knee brace we usually use for patients who is having instability. So sometimes patient is not confident. Whenever patient is going upstairs or downstairs, patient is scared that he might fall. He's having less strength in the knee. So for those individuals, the knee braces would would really help. And offloading knee braces, these are something which can, these braces can avoid the need for a surgery altogether. Because in the knee joint, so when one compartment, so you're having three compartments in the knee totally, but most of the loading happens either in the inner compartment or in the outer compartment. So what these braces do is they help in redistribution of the forces. So when one compartment is getting loaded, the brace will try to basically align the limb in such a way that uh, that portion of the knee which is not involved in load bearing will start getting loaded. That way the load distribution happens and the joint also opens up a little. When the joint opens up, again the lubrication will be better, the cartilage restoration will be there, and there is a high chance that the arthritis can also get reversed. So all these three I would want everybody to understand. So every patient will need this, some patients will need this, and very few patients will be needing this. But an offloading knee brace will really do wonders. It will completely avoid the need for surgery. Now, as I had already discussed before, this hyaluronic acid. So this we give to grade 3 patients, usually grade 2 and then to grade 3 patients whenever the arthritis is progressing at a very fast pace. So what we do is we give this so that good amount of joint lubrication happens. So when the joint lubrication happens, there is free movement. There is free movement. The inflammatory parameters also will reduce. The range of movement also will be better. Now, there's something new which has come to the market is this PRP injection, which is called as platelet-rich plasma. I'm sure most of you would have heard it. So in this, what we do is we take your own blood. So we take the patient's blood. We usually prepare it. We know that the blood has got RBCs, WBCs, and platelets. So this platelets has got very good healing potential. They have got something called as growth factors. So what we do, we take some amount of your blood, we process it, and from your blood, we extract a very high concentration of platelets. Because the more platelets we get, the more the growth factors. And then we immediately inject into your knee joint. So initially, some amount of pain will be there, but the advantage with this is we are using your body's own natural healing power in order to heal the knee arthritis. So this will do wonders. Again, grade 2, grade 3, this will really work. But grade 4, again, since there'll be bone on bone arthritis, the PRP injection will not help. But during our study recently, we have identified that we could, in fact, the patients who needed surgery in the next 6 months to 1 year with this injection, we could completely avoid the surgery. They have recovered significantly. So patients might need close to 3 injections monthly once. Some patients have recovered even with a single injection as well. Now, the important question. So, when do you need surgery? Now, you're having knee pain, you're having swelling, you're finding it difficult to walk, your knee is becoming stiff, your activities of daily living is all getting affected. Now, when do you need surgery? What is the clear time? Now, after all the treatment options have been exhausted, medicines didn't work, the injections didn't work, the braces didn't work, the physiotherapy didn't work, the exercises didn't work, your activity modification didn't work, then it means that your knee is crying for help. So probably you're in grade 4 arthritis, which will need a surgery. Sometimes if you're having wrist pain, even without doing anything, if you're having wrist pain or if you're having night pain, that's again a red flag sign. It means that your knee needs an intervention, a surgical intervention. And suppose because of the pain, your activities of daily living, preferably indoors, when your indoor activities are all getting affected, you're not able to walk, you're not able to climb stairs, even walking inside the house is getting affected, then probably you'll have to start planning for a knee replacement. And very important thing is the structural deformity. So sometimes because of the wear and tear which gets localized towards one part of the knees can be bent. It can be either bent inwards or outwards. So whenever a knee is bent, so that's an indication conservative management will not work. So if you're trying with all these injections and exercise and rehab and medicines for a deformed knee, it is not going to help you. You will need surgery. Now, talking about surgery, so what are all the options we have? It's just not a knee replacement. We have something called as a high tibial osteotomy. I will explain to you in the next slide what we do in the high tibial osteotomy. So we also have something called as a knee arthroscopy. So in this, what we do, we pass the camera inside your knee, and then we try to clean the knee inside. So whatever inflammatory parameters are there, whatever small joint damage is there, cartilage erosion is there, what we do, we pump fluid inside, we pass a camera, and then we clean up the knee joint completely so that you'll get good amount of pain relief. And again, replacement, we have two types. One is a partial knee replacement and a total knee replacement. I'll explain to you in the subsequent slides. Now, what is this high tibial osteotomy? So high tibial osteotomy, who are the patients, for whom it is indicated? Now, when we look at this X-ray, we can see that this is the thigh bone. The thigh bone is straight, but the leg bone is again bent. So when the leg bone is bent, what happens is the inner side, there'll be a lot of stress concentration because most of the load starts going from here. So for such individuals, wherein the knee is bent, there is an angular deformity, but there is no extensive arthritis. When you see there is some amount of gap here and a good amount of gap here. For these individuals, we do something called as a high tibial osteotomy, wherein we make a small crack in the bone here. We make the bone straight and then we fix it like this. So this is called as a corrective osteotomy. So we make a small surgical correction of the default of the deformity, whatever is bent we make it straight and then we fix a small plate with screws so that load distribution happens on both the sides instead of load distribution happening only on one side. So with this surgery, so this is not a replacement. So once we do this, we can avoid a knee replacement altogether. So if we don't this, so once we have identified that there is an angular deformity, and if we don't treat the angular deformity, eventually we'll have to do a total knee replacement. So the moment we identify this, it is better we try to correct the angular deformity so that your original God-given knee will still be there. Yeah, okay, so this will do wonders. Second is the knee arthroscopy. As I've told you, we pass the camera inside and we just clean up the knee joint inside completely so that the whatever the all those components inside the knee, all the damage, the debris, all the unwanted stuff, whatever is there inside the knee, will all get flushed out and the knee will become free. Now, coming to this entity called the partial knee replacement, I think most of the individuals might know just about a total knee replacement. Now, partial knee replacement for whom do we do? So, when only one compartment of the knee is arthritic. So here we can see that the inner half is completely arthritic, the outer half is good. So for these individuals, it doesn't make sense to go and do a total knee replacement because the outer half is still good. So why should we replace something which is good? The cartilage will be good, the joint space is good. So here we see that the joint is completely damaged. So what we do, we go in and this is more like a joint preservation surgery. So we just replace only the half of the knee. So in this, the bleeding will be very less, the pain will be less, surgical time is very less, and in fact, the patient can get back to all his routine activities immediately after surgery. So this is the image which shows here. So this is the arthritic part. So we just replace the arthritic part. Now, what is total knee replacement? So in a total knee replacement, what happens? Both the sides, the right side, the inner side, the outer side, as well as the tibial component, everything will get involved. So most of the time, it will be great for arthritis. So in this great for arthritis, what we do, we replace whatever is damaged and completely gone. So all this erosion, there'll be so much of friction. Imagine a patient trying to walk with so much of erosion here and erosion here. That is why they start hearing all those sound. You hear the tuck tuck sound. You'll feel like gravel. When you touch your knee, when you're bending the knee, you'll feel like there is so much of friction inside the knee. That's because of the uneven surfaces which are touching against each other. So for such individuals, what do? We go in and replace both the sides. So like this. So we replace the inner side and the outer side, both the top and the down. So in this way, what happens is the metallic component articulates with this plastic component here, and there is a metal here. So there'll be smooth gliding movement inside the knee joint. Now, very briefly, I have explained now. So in case you have any doubts or queries about arthritis, knee pain, sports injuries, management, how to tackle any of your symptoms, you're free to ask me questions now.
So thank you very much, doctor, for your wonderful presentation. I think you are explained in detail about the pathology and how the knee pain starts and what are the various treatment options. That too,
Yeah.
in the surgical procedure, you were talked about the high tibial osteotomy and the uni knee, which is very unique. Actually, most of the people are not aware about the uni knee and what is meant by high tibial osteotomy and all. So
Yes.
that is wonderful, sir. And with your kind permission, you have talked about the braces actually. So I'd
Yes.
like to share some few informations about the off-roading braces because most of the time people are not able to differentiate what is meant by off-roading brace and normal knee sleeve. Just a
Yes.
quick information I would like to share. 1 minute, doctor.
Sure.
Just a minute. Just a minute.
Yeah.
So I think already, 1 minute, sir. I'll close my screen. So you had already explained about the offloading braces. What is mean by offloading braces and all? Okay. So just I would like to brief about what is the role of braces in osteoarthritis as a conservative treatment. Okay, most of the time, everybody know there are different type of braces are available in the market. Okay, so the most common thing, most of the time, people who knows about this type of knee slips, which are very common, quite common nowadays. People are buying the braces online, or you are buying the braces in the shops. But that should not be right way actually, because whether what is that the normal compression sleeves is going to give some kind of compression and it helps to relieve the pain. But the most common thing, most important, the reason for the osteoarthritis is the weight actually. The weight goes to that particular compartment. That is what you also highlighted, that the weight management is more important. So the off-roading braces is nothing but actually to help to relieve the stress on the affected compartment. That is what there should be some mechanism for that. Then only the brace is called actually an offloading brace. So the our offloading brace comes with that type of mechanism. I'll explain to you in a brief immediately. You can see that there is a thumb wheel dial is there, which helps to push it from the opposite side and open the joint space actually. If you see the X-ray, na, you can see in the before without brace, you can see with the brace, there is a joint space increase on the opposite side. You can see that. So once the joint space increased with the help of an offloading brace, what happens? The pain will stop, or sometimes it reduces immediately, and the disease will not progress further. That is what the benefit of offloading braces. So this type of benefit you are not going to get it with the normal hinged knee braces or even with the knee sleeves. So that is the difference between the offloading braces and the normal hinged knee braces. You can see this type of things. I'll show the video. You can see from this video, forward this video, how these braces are working.
Braces for osteoarthritis are known as offloading braces, like Bregg's Fusion OA and Freestyle OA knee brace. Breg OA braces gently apply pressure to the unaffected side to align the knee, taking pressure off of the affected side of the knee. The higher the number on the thumb wheel, the greater the amount of force on the knee. These before and after x-rays show how Breg
You can see that now before and after there is a joint space increase. So this is the way it helps actually. So this is a very simple brace. If anybody wants to try in a Bangalore, we are ready to give that free trial. Okay, maybe you can contact and send a message to the WhatsApp group. They will arrange for a trial for this product brace actually. If you want, you can try and you can check it how it is going to help for you. Okay. So, and another one more important thing, doctor has explained about the exercise actually. Even we have, if anybody wants the American Association of Orthopedic Society recommended exercise booklet available. If anybody wants, just share it. So just text me in the WhatsApp group. So we are going to share that link also to you, so that you can talk to your doctor, or even with a physiotherapist, you can try to do some kind of simple exercise in the home actually. So with that, I'm going to stop now. So thank you very much, doctor. Just a minute. Thank you, doctor. So now let's move to the question and answers, sir. Actually, already we have collected some couple of questions from the audience actually.
Okay.
To go one by one. Once we have completed this question, then we'll go to the audience if they are having any other questions.
All
Doctor,
right.
a question called actually, what can be done for knee arthritis with the swelling, stiffness, and pain while walking?
Okay, so if somebody is having swelling, stiffness, and pain, so each one we'll have to tackle. So somebody with swelling, so since the joint is swollen, what we need compression from outside. So they will have to wear some kind of a splint. So preferably a kneecap. Okay, so that will give some amount of compression. And since there is swelling and pain, icing has to be done, because if there is swelling associated with pain, it means that there are a lot of inflammatory buildup. All these inflammatory parameters would have all they would have all built up inside the knee joint. So they'll have to do some icing. They will have to wear the kneecap. And since they're having stiffness as well, they'll have to do some kind of a mobilization exercise, whether they'll have to bend the knee, straighten the knee, and they probably might need to take the help of a physiotherapist as well. But any patient who is having all these three, pain, swelling, and locking, so they can try all this initially, but if the symptoms are still persisting, they will have to get an X-ray done sometime soon, because the restriction in the range of movement. So pain is fine, swelling is fine, you can manage at home. But if there is locking sensation, if the patient is not able to move the knee freely, probably there is a bone-to-bone block. So they'll have to get an X-ray done, and accordingly we'll have to handle it.
Okay, thank you, doctor. I think whole therapy, that is the kind of eye therapy, is going to
Yes,
help for the patient.
yes, yes.
Okay, good. Thank you, sir. So, why does the knee pain become worse while climbing or coming downstairs? Actually,
Okay, so
this is
usually
very
when,
common.
yeah, when we are standing, or when we are walking on an inclined surface, so there is not much of a joint reaction force. So joint reaction force means the force which the muscle gives, the calf muscles, the thigh muscles, the muscles at the back of the thigh. So all these three are the important groups of muscles which are important for walking. When you're normally walking on a normal surface, or when you're standing, there is not much work for these muscles. Now when you're going upstairs, so you're walking against gravity, which means the muscle has to generate a lot of force. So that increased force is getting transmitted to the damaged joint. So that is why while going upstairs, again, your pain increases. Again, while going downstairs also, sometimes patients will tell us, that they have a lot of pain. They have more pain while going down than while going up. Because again, here it's again because of the muscular forces. The joint is arthritic, whether you're walking on a flat surface, whether you're standing, or whether you're going on an inclined surface, or you're going upstairs or downstairs, the arthritis doesn't change. But what happens is, when you're going upstairs, you're walking against gravity, the force generated by the muscle increases a lot, and all that force get transmitted to the joint, to the damaged joint, which will lead to pain. When you're going downstairs, what happens again? You might argue, okay, that is not against gravity. We are coming down, so gravity is we are coming. It should be easier for us. But again, what happens is, when you're coming down, your muscles will try to protect the knee, because since you're going down, in order to stabilize the knee, or else if there is no stability, you'll quickly walk and then you will fall. So again, in order to block the knee, the muscles act. So it's basically because of increased joint reaction forces, because of the muscle contraction. Same thing applies even when you're sitting and then getting up from a seated posture. When you're sitting on a chair, when you get up, you will start getting a lot of pain. Again, why? Because when you're getting up against gravity. So which means that the joint reaction force will be more because of the muscle contraction, the muscle forces.
Good, doctor. Thanks. Maybe what you are highlighting here, to strengthen the muscles, is also more
Strengthening
important.
is extremely important.
Yeah, that's why most of the time giving importance for the quadriceps and the hamstring strengthening. That is what is more important.
Yes,
Okay,
yes.
doctor. Thank you very much. And then there is a one more question. Why does the knee pain become severe at night and disturb sleep?
Okay. Now again, so during daytime, what is happening is, you're always either standing or you're walking, you're active. So the joint, what happens is, the whatever the inflammatory parameters all would have accumulated inside the joint, they don't settle down. Okay, so you're always moving, the joint is moving, the fluid inside is moving. So what happens during night is that the joint becomes completely, it gets blocked. So with this, what happens is, the muscle forces will keep acting. The inflammatory parameters will start, settling down. There is no joint lubrication happening, because everything becomes static. When that happens, again, the bone-to-bone contact increases, the pain increases, and that is why sometimes the pain will even wake the patient up in the night, and sometimes morning when they get up, they'll feel that their knee is extremely stiff and locked. So
Okay.
how do we prevent this? You should basically strengthen your muscles a lot, and then ensure that you take some kind of a anti-inflammatory medicine before you sleep in the night, and also do icing before you sleep, or else all these inflammatory parameters will settle inside the knee, and then they will start irritating the knee. And once you sleep, you'll start, the pain will start waking you up from sleep in the night.
Okay. Thank you, doctor. Doctor, it's regarding the treatment option actually.
Mhm.
What are the treatment options for grade 3?
See, grade 3 arthritis, you're in that gray zone. You might, anytime you might need surgery, or else you might even be saved from surgery. That is the stage in which you're in. So grade 3 arthritis, I would definitely recommend the patient to change their lifestyle immediately. Avoid squatting, sitting cross-legged, avoid lunges, and joint health is extremely important. Good amount of strengthening exercises of the knee. If the pain is there, better to get injections done inside the knee joint and then do bracing. So with this, most of the time, grade 3, we can halt the progression of the arthritis from grade 3 to grade 4. Medications, exercise, physiotherapy, injections, and bracing. These five modalities will suffice to prevent progression. But in case we are not careful in grade 3, there will be very rapid progression to grade 4. Most of the patients with grade 3, again, we can manage conservatively. They will not need surgery. Just that they will have to manage their joint health with all these non-surgical options. Exercise is very important. Exercise and bracing is what is important during stage 3 arthritis.
Good, doctor. Thank you. Doctor, when a patient has been advised to total knee replacement, how
Mhm.
can they decide whether the surgery is necessary? How they are going to decide? Am I a right candidate for a surgery?
Okay, so whenever the patient has been advised any replacement, so what are the things the patient should be very cautious is, one, if they're having night pain, if they're having rest pain. Okay, let us assume all the treatment options have been exhausted. The medicines, physiotherapy, exercises, strengthening exercises, injections, even bracing has been done. So even offloading knee brace or a normal kneecap, everything has been done, and still the patient is having pain. So what are all the criteria? Even after exhausting all the non-surgical options, if the patient is having pain, if the patient is having rest pain, if the patient is having night pain, and very importantly, if the patient is having deformity of the knee, then it's an indication that the patient has to get operated. So though the doctors might advise surgery, if they're having any of these four, exhaustion of all the conservative management, there is deformity, there is rest pain, there is night pain, then the patient has to undergo a surgery.
Thank you, doctor. I think you are already discussed about the PRP injection and
Yes.
hyaluronic and all. So there is a question related to that.
Mhm.
What options are available when gel injection, PRP injection, and physiotherapy are not provided relief?
So when physiotherapy and the injections has not given relief, so what we have to do is, sometimes with a single shot of injection, the patient might not get relief, because patients come to us during the advanced stage. They come to us little advanced, wherein the knee joint is already arthritic. So for them, one single injection might not help. I would request them to repeat the injection. Okay, whether it is PRP, whether it is the visco supplement, whether it is a bone marrow aspiration concentrate, whatever injection it is, repeat the injection, and also please wear a brace. Okay, if there is loading on one side, so if there is loading on one side, please use a offloading knee brace, please wear a kneecap, repeat the injection, and wait for a month or two and see. But if this lack of relief with the injections is causing pain, then probably you may have to contemplate for a knee replacement.
Okay. Thank you very much, doctor. And there is a question related to the meniscus. If
Mhm,
there is a meniscal tear,
mhm.
okay, is how is osteoarthritis with the meniscal tear treated when the
Okay.
patient is unable to walk properly?
Okay. Now, when we see what the meniscus does, so meniscus is like a rubber padding. It is like a rubber padding between the thigh bone and the leg bone. So it acts like a shock absorber. Now, what happens when a meniscus gets torn is that the shock absorbing function is gone. So once the shock absorption is gone, bone to bone contact happens. So that is why arthritis happens. Now, when any patient has a meniscal tear and is in the early stages of arthritis, meniscal tear with an early stages of arthritis, better to get the meniscus repaired. The moment you get the meniscus repaired, sometimes the arthritis also can get resolved. Suppose if there is a meniscal tear with advanced arthritis, then we cannot try to save the meniscus, because it means that the meniscus is completely crushed and the patient has already gone to the stage of advanced arthritis. Then probably we'll have to remove the meniscus, remove the damaged portion of the knee, and then we'll have to do a knee replacement. But anytime, if the meniscus tear is identified, it is better to get a meniscal repair, because just by repairing the meniscus, you are saving the joint, you are preserving the joint. But if the meniscus tear, if it is torn, you don't repair it, definitely arthritis will happen very soon, and you will come to us for a knee replacement itself. So meniscus tear with arthritis, if it is early arthritis, get the meniscus tear repaired. If the meniscus tear with advanced arthritis, you'll have to go for a knee replacement.
Thank you, doctor. And there is a one question actually from the participant. I don't know whether he is in the meeting now. He
Okay.
underwent a left knee replacement on 7th May,
Mhm.
maybe a couple of months back. Still, he is having a swelling, warmth, and a knee range of motion approximately 90 degree.
Okay. So if
What
you
should
have
be
got it
done?
done on 7th May, then probably July, August. So July, August. So it's been around just around 2 months now.
Too late. 2 months, sir, actually.
Just around 2 months. So, see, for 2 months, pain and swelling is very much anticipated because swelling might persist for somewhere between 6 months to 1 year. Patients need not worry about the swelling because we have removed the damaged knee and then we have put an artificial joint. So, swelling is not a point of concern. Pain at the end of 2 months is still okay. Pain is still okay. But what is concerning is that 90 degrees movement. So 90 degrees, the range of movement at the end of 2 months is a little less, so that the physiotherapist will have to work a little. The patient has to do an extensive physio, basically the stretches of the knee, so that the knee range of movement will increase. Icing can be done, some amount of compression can be done, but they need not worry. Pain, swelling is extremely normal. Swelling until 1 year is normal, but the knee bending until 90, only that is a point of concern, which we can still take care with the help of physio because it's just been 2 months after surgery.
Thank you, doctor. Normally, what should be the range of motion within a month, doctor,
See,
after the
within a month, for patients who are thin, they can reach 90 to 120 degrees easily at the end of 1 month. But 90 degrees should be the minimum, which every patient will achieve after a knee replacement.
Okay.
90
Is
degrees
there
is the minimum.
anything? Okay.
Yeah.
Is there any significant changes you can able to notice when you are doing a robotic knee replacement with the normal conventional knee replacements?
Yes. So what happens during robotics is that during robotic knee replacement surgery, there is not extensive bone cut, so we don't open the knee joint a lot. So the incision is small, the surgical incision is small, the joint damage is minimal, the soft tissue damage, which is the muscle and the surrounding tendons, they will not get damaged so much. So since the surgical incision, the surgical site will be small, pain will be less, bleeding will be less, soft tissue healing will be better, recovery will be faster. But when you ask, at the end of 3 months to 6 months, is there any big difference between a conventional knee replacement or a robotic knee replacement? There is absolutely no difference. Both the patients will do well, but the advantage with the robotic is patient will recover faster and return to normal activities will be much earlier than a conventional knee replacement.
Okay, thank you very much, doctor. There is a question from the audience actually.
Mhm.
Pavitra, you can talk to the doctor directly. You can unmute and talk. Hello. So she sent a message. Knee pain at medial side, age 35. What is
Okay.
the cause actually?
Okay, for somebody who is 35 years of age, so what I would like to know is whether there was an injury. First is whether there has been injury, like any accident or a workout related injury, or whether the pain is sudden in onset or gradually it has come. So usually for somebody who is 35 years old, definitely there will not be joint damage. There will not be joint arthritis. Probably the patient might have had some kind of an injury, either a workout related injury or a work related injury, or sometimes activities like dancing or playing badminton. So here again, the patient has replied that there is a
Falling history.
history of
Scooter.
fall from scooter. So if that is the case, sometimes there can be a possibility of a meniscal tear, usually medial sided pain. So towards the inner aspect of the knee, when there is an injury after a fall, the meniscus usually gets injured or torn. So I would advise the patient to get an MRI of the knee joint to find out if there is a meniscal tear. So if there is a small meniscal injury, we can just try with some kind of medicines. We can do some rehab. We can do some physio. And if the pain is still persisting after 1 to 1.5 months, we can give the same PRP injection to the knee so that the meniscal tear can heal.
Thank you, doctor. I think definitely, Pavitra, you need to address this meniscal injury immediately. Maybe if you want to talk, meet the doctor. If you are in Bangalore, we are going to share the address, or else even nearby any doctor also you can consult immediately to avoid further damage. Actually, So, is there any other question from the audience? If you have any question, please talk to the doctor directly. Doctor is here now. You can unmute and talk to the doctor. Please raise your hand. We will allow one by one. Doctor, one more question finally.
Mhm.
How should the early OA be managed to prevent further progression? Because this is the very real concern actually right now. Most of the people are coming at the later stage and they are looking for some immediate option, conservative treatment option. Even in the grade 4, we got some questions also. Is it
Mhm.
possible to treat conservatively in grade 4?
We can always give a trial of conservative management in grade 4. Just because a patient has come to us with an X-ray which shows a grade 4 arthritis doesn't mean that straight away we have to, you know, push them under the knife. We can always try with a conservative management, but in grade 4 our options will be limited because we cannot give them injections, any sort of injections, because there is already bone-to-bone contact. So the injection is just going to be a waste of money for them. They can definitely try with bracing. They can definitely try with some kind of a physio and then rehab, and probably a corticosteroid injection, the steroid injection inside the knee joint. A steroid injection inside the knee joint will definitely help them to get some kind of a pain relief. But again, the gel injection and the PRP injection will not help. So somebody in grade 4, let them try with physio, with a steroid injection inside the knee, and with some kind of a bracing along with exercises, so that the progression will slow down a little, but it's never going to reverse. That we have to be extremely, we have to be very much practical there.
Yeah, that's wonderful, doctor. Because most of them are thinking when you are going to consult a orthopedic doctor, they are pushing for a surgery. Okay, that
Correct.
is what the myths everybody is having. That it is not mean that all the doctors are not pushing the patients to knee replacement. Because
Yes.
when you are coming with the grade 4 or the last final stage, they don't have any other option apart from the surgery. Then only they are
Correct.
pushing you for the surgery.
Mm.
Even not pushing, they are recommending for a surgery. Then the decision will be left to you.
No, but
Okay.
ideally, though they come in grade 4, I think we have to give nature one last chance to heal. I think we have to try with conservative management once, even if it is grade 4. Even if it is grade 4 arthritis, it is completely fine. We can still try with conservative management once. Even then, if it fails, then probably we can plan for any replacement for such patients.
Thank you, doctor. Is there any question from the group audience, please? You can ask to the you can talk to the doctor directly because you don't get an opportunity to talk to doctor directly. Otherwise, you need to go to the hospital to consult, get an appointment, and all. Is readily available right now. If you have any question, please raise your hand. We are going to allow you, or else you can send a message in the chat box. Okay. I think there is no question, doctor, because already they have sent a lot of questions and you are already addressed that.
Mhm.
So thank you very much for your wonderful, not only a presentation, and you are explained each and every questions in a detailed manner. Especially when it comes to even in the grade 4, there is a hope for the conservative treatment. That is
Yes.
what the message you are already conveyed to them, and already you are conveyed the early management is also more important. So people has to address it in an early stage, then it will be very easy to treat. So that is what the message everybody has got. Uh, Participants, if you want to try the offloading braces, we are going to share the detail. And if you want to consult the doctor, we are going to share all the details about the location, address, how to get the appointment and all. We are going to share it in the group. So thanks for joining. And thank you very much, doctor, once again, on behalf of Avana Surgical. Thank you very much. And thanks for joining all. Thank you very much, doctor.
I thank everybody, for taking your time out and then attending this webinar. I hope it was of great help to you. But anytime, any help, you can either visit me or you can even take the contact number of the Avana team, so they'll be able to help you out with those braces as well. I also thank the Avana team for giving me this opportunity. I hope that the patients would have got benefited with this. Their knowledge and insight about arthritis would have improved a little, so that I hope you are all able to take a proper conscious decision. But in case you are still not able to decide, you're always free to visit us. We'll help you with that. Okay, thank you. Thank you, everyone.
Thank you, Doctor. Wonderful, Doctor. Thank you very much.